So thank you all for most interesting presentations. We do have about 30 minutes for discussion with panelists and with Dr. Androulis. So we'll take questions from roundtable members first, and then if there's time, we'll open the floor to others who perhaps would like to ask some questions. I would appreciate if you would identify yourself when you come to the microphone. It's just a little difficult with the lights shining on us here to perhaps identify, so that would be helpful for the audio piece. So if you'll come to the microphone, we'll begin the question and answer period. Michael, let me begin with a question that I have, and maybe you can help me think this one through and discuss it further. As I think of the drivers of the delivery of health care when it comes to the provider teams, I think of 4 Ps: professionalism, performance, patience, and payment. And if we think about the business case, there may not be a business case. And so I'm concerned about the use of the term business case when it comes to the cultural competence, linguistic competence that we've been discussing this morning. I prefer to think of it as an ROI, a return on investment, rather than maybe a little bit of a difference. I'm not an MBA guy, but as I think this through, and I'll tell you why. We just, matter of fact, Friday night, we just celebrated the 20 years of our Dolan Family Health Center, which is a center for patients, a vulnerable population, underinsured, and with a variety of cultural competency issues. And after 20 years, we probably looked at 25,000 visits a year, and I don't know how many thousands and thousands of babies and all sorts of good stuff, really good stuff. But when we started 20 years ago, our chief financial officer said, "Where's the business case?" He said, "There's no business case to do this. We're going to lose a lot of money. And where's the income?" And indeed, that is a problem. To this day, we still lose, the hospital, which runs it, loses about $600,000 a year, about. So but if you look at the ROI in terms of healthy community, healthy population, healthy babies, all the other things that you produced, it seems to me that's a better discussion than the business case. Am I wrong?
I think it's a semantic issue. I agree. I think that a business case in some ways is a return on investment. I think from our end of it, that is the language we've been hearing quite a bit about is what is a business case. So are you looking either as a cost savings versus, I don't think maybe this is, again, I'm not an MBA. The green light is on, so is this better? Can you hear me? I could just talk louder, but.
How about this one?
Use a different mic? Yeah. Okay. Oh, big difference. Oh, okay. Well, either. Is this right? Okay. I got lots of mics coming at me.
Well, Michael deserves a lot of mics.
Yeah. So I think the business case, for me, it's a semantic issue because I'm not an MBA person either. So I think whether it's cost savings or however we frame it, it's been what's been posed to us as well. And I agree with you that a lot of times, and even to your point on prevention, people oftentimes, it's like, what's the acceptable loss? In fact, as an example, we have a project right now with a large, one of the largest national pharmacy chains, and when we were trying to sell this health literacy initiative with them, they came and said, "You've got 4 things that you have to help us figure out. 1, are we getting ahead of an eventual mandate that we're going to have to do this anyway? Then we'll consider it. 2, are we going to sell more product?" That was the big issue for them. 3, is it a safety initiative that we think that we might be able to kind of pose? I mean, they're very much wanting us to kind of find a way to thread this through. I do think, though, that that in some ways, and this maybe gets at some of the measurement piece, is that if you start to frame that there are certain groups within your population, and this is probably not the best way to think about it, and this is why some cases I was thinking, we're trying to get away from the risk factor mentality of health literacy and thinking of it in the larger context, which gets us away from how a large and expansive the literature has kind of taken us. But it's a risk factor mentality of that there's a at-risk group, and if I could only identify that group and I could allocate more resources to that group, then that would actually work. And I think that's what maybe some payers are also doing. They're trying to segment groups to kind of recognize that you're going to get this resources, and therefore we're going to reduce the, maybe more burden of expense that this group is going to have. We probably don't want to be there. We want to have people thinking that this is a right thing to do, that they're going to get return on investment, and that it's a matter of improvement in healthcare quality, that they are going to have some safety events that are going to be reduced. But yeah, I think however we sell this, we've been challenged to try to view this as a quality indicator in some regards to get our health system to kind of, especially actually post, we're jumped ahead to value-based design right now and thinking about how does this even fit into it. And the way they approached us in our own healthcare system is we'd really like to have some of these metrics in place because we think that we can bundle it within the value-based care model. So maybe that's another angle.
That's very helpful. Yes, certainly.
I just want to build off what you're saying, because I think the concept of business case gets tied up in linear dollars and cents. Show me the bottom line, when there are so many other things that are, it's a complex issue. And that adds to the challenge, but it also, if you look further beyond the pure linearity of, if I invest this, will I get a return? That is of monetary value. There are other characteristics that you touched on, the concerns around now readmissions. It kind of hit organizations where it'll doctors that end up spending more time with patients that they're ticked off about, because why is it? I mean, I've raised with practitioners before the lack of attention, as I'm sure you have too, to these issues, how it's costing you in your work. People who come in who, if you don't pay attention to the culture or literacy of language issues, they're back in your clinic. You go, what the hell are they doing back here again? And you realize that a person didn't understand or doesn't relate to these, the way in which you've administered meds or otherwise. So what you have to do is kind of be specific and recognize and expand the concept of a business case. So it involves regulation adherence, what's coming down the line in terms of other requirements, opportunities through new innovations that could embed in this aspect of it, and the ability of practitioners, health professionals, and the team to be cost-effective in delivery of services. And then, of course, what you raised about quality, safety, all these. So the idea is you have to coin a phrase we've raised earlier, you have to deconstruct the term business case and say, what are the real dimensions of business case? And then how can they apply in different ways? And how can I prove the case in these multiple dimensions to the world in which we are delivering care?
I think, oops, can you hear me? I'm sorry.
Yeah.
Okay. I think one key element in terms of, building the so-called business case or the value of providing or addressing health literacy or cultural competency is the importance of collecting data. We are now becoming a data-driven kind of society, and analytics is big. It's big. I mean, analytics is driving policy, it's driving programs, it's driving initiatives. It's looking at costs. So if you look at what are the barriers in terms of that, let's say, patients bring to that clinical encounter, could it be literacy, could be cultural competency? So as you start documenting that, I think that gives you the leverage to start building that so-called business case. And I think, I think analytics and building that database, collecting that data will drive providers to address the needs of patients with health literacy and cultural competency kind of issues.
Well, more of this to come. Is that Ruth Parker that I see over there?
That is. So I guess the question I have, Dennis, I love the LLC, and it's not a limited liability corporation, I know, but I like that. So my question with the thoughts about framing relate very specifically to the last comment, Bernie, and the business case. Is anyone writing or talking about LLC and value as sort of a different framing than the business case and a different way of getting at value? Since value is so much on the agenda, triple aim, everything else. But what about LLC and value? And, it's embedded within some of your things, but I just wondered if that's being advanced anywhere with these constructs part of it.
Not that I know of. No, honestly, it's there in pieces. And that's why I think the timing of this workshop is important in the sense of re-elevating its visibility, and getting back to Lupe's point and others about grounding it. I mean, when I was sitting here, I was thinking, actually what we need is the NIH to embrace this in a series of demonstration projects or some kind of assessment where you're actually doing studies that have experimental control groups. What ends up happening, the world needs a foundation for this work, and a foundation grounded in data, in real life experience, not just anecdote, not just advocacy, but it needs all these elements that prove the value. And I think to date, there is what we've seen from Enroller Sister. I'm thinking of the Enroller Sisters, for example. The Enrollers and Sisters are just doing these actions, undertaking these actions by the nature of what they're required to do in their jobs. And I'm thinking, where have I seen this written up? Where have I seen this studied? Where have I seen it looked to? I haven't seen anything on it. Yes, important, but the actual grounding and the synthesis of it and the promoting of where we need to go, no.
And is this on? Well, sounds like it now, right? And I think that's where the world of language, can you folks hear me? Yeah? Okay. And I think that's where the world of language access really would need to partner with others regarding this, because as you mentioned, anecdotal, as interpreters, we're aware of the clarity of the information that has been provided, but what would have happened if it wouldn't have been? So, for example, if I'm interpreting for a patient and a situation unfortunately happened where they thought they were communicating with this patient in the absence of an interpreter, later as we questioned a procedure, it turned out that he was missing one lab that he needed to have done as required by New York State. However, with the absence of the interpreter, he wasn't aware of that. So had he shown up for surgery, they would have had to cancel the procedure. So all that scheduling and putting everything in a way that should have happened smoothly wouldn't have. So how do we capture that? And that's a question that I know we're not going to answer today, but putting it out there.
Rima?
Indirectly, I'm addressing issues of measurement, but I just want to offer a brief note about why I haven't successfully grappled with the issues in culture, language, and health literacy, and integrating all of them. One, with the issue of culture, there seems to be still an insistence that we take our culture, i.e. our interpretation of health and medicine and nursing, for granted. And we spend a lot of time trying to learn the culture of the other. And I think we need a deeper analysis of what our culture is, and to understand what our biases are, what our limitations are, what our values and assumptions are, before we could really understand the culture of the other. So the issue for me is really an issue of explaining and negotiation, which is good communication. When we think about translation or interpretation, as far as I understand it, the ethics of a good interpreter is really to be true to the statement that's being made. So there is the danger of translating jargon from one language into jargon in another language. And here, too, I think we need the issue of negotiation and explanation that requires time and requires effort beyond the mere change from one language to another. I always think of, this is the sequel to Alice in Wonderland, Through the Looking Glass. Humpty Dumpty has a long conversation with Alice. And what he says to Alice, you know, when I use a word, it means exactly what I want it to mean. And in a sense, there's no room for interpretation. There's no room for explanation. Of course, we know what happened to Humpty Dumpty. And I'm worried that that's the exact same thing that will happen to us. So in some ways, the notion of interpreting or translating from one culture to another without lengthy, detailed explanation and negotiation and respectful dialogue, we can't really integrate health literacy, because we can miss the boat with language. We can miss the boat with assuming that our culture is the predominant culture and we have to just understand the other side. There are dangers there, and I don't know how you integrate it. So maybe, where's my question? Wilma, Wilma, what do we mean by language access in face of the dilemmas that would, with culture, with interpretation, with meaning?
Well, here, I'll try to respond to that. Thank you for your comments, Rima. All right, so one of the things, you know, it's not a hard and fast rule that we can't change. We don't change whatever we hear, right? So whatever hits our ears is what, according to our code of ethics, we're obligated to interpret. So that's why sometimes interpreting for providers is like really tricky. And so I wanted to share with you an example that happened on a unit, and this is my long-winded way of responding to the question. So I'm interpreting for a patient. He's heavily sedated, you know, he's very complex, and he was in the ICU, very heavily sedated for his own protection, let's put it that way. So the family comes in, and his sister, I'm interpreting if she is the one with healthcare proxy, and, you know, then I have to go through that whole delightful situation. So we get to the actual visit, and the patient's sister, the nurse starts by saying, well, do you have any questions? And the sister said, well, you know, why are his hands so swollen? And the nurse said, well, it's a physiological response. It's a physiological explanation. Well, I interpreted that. Let me tell you, I had no idea what that meant, but I could interpret it. Okay? Those were her words. My obligation as an interpreter is to convert it. So I did. So then the patient's sister looks at me, and the nurse looks at me. And remember, I'm supposed to be transparent here. This is not the Wilma show. And so the nurse looks back at the family and says, well, that's the only explanation I have. And I lost my transparency, stepped out of a conduit role. I didn't know if I needed to go into a cultural broker role or a clarifier role, but I went into my advocate role. And I don't know if any of you are aware of the different roles that we navigate within, you know, one situation. So I asked permission to clarify. I turned to the patient's sister and I said, one moment, as interpreter, I need to clarify something with the nurse. So I turned to the nurse and I said, as interpreter, is there something else you'd like me to interpret? For example, if she has any questions about that. Because now I'm in a position of having to say, not doing anything to taint the outcome and cause the nurse to lose face, right? And this is all going on like in 2 seconds. And so the nurse said to the sister, well, did you understand that? And I interpreted, no, I don't know what that means. And so this is where the rubber is hitting the road. I interpreted a term that I'm familiar with because according to my code of ethics, if I'm calling myself an interpreter, my vocabulary is all over the place. However, what I do with that in that moment is really going to impact that outcome, and I have to be very, very careful. So it really is helpful when the provider is aware of what they're saying and what they're presenting so that it would be something that would contribute to well-being and good outcomes to this patient. Because we all know this happens English to English, you know? And so now we're adding a cultural and linguistic layer to it. I'm not responsible, nor would I pretend to be responsible for the words of others. But what I can do as somebody who is trained in this area and always learning, right? You're always learning, is to try to be a resource when you're the only one in the room with a foot in both worlds.
Could I respond?
Yes.
When I think about health literacy or cultural competence, to me it's about communication, basic communication. You know, making sure that that patient understands what you're trying to convey in terms of the diagnosis, in terms of the treatment protocol, et cetera. If you look at two settings, let's say, and it's the culture of medicine, let's say the culture of a hospital is a lot different than the culture of a federally qualified health center. Right? It's day and night. A federally qualified health center who's in the community has staff that represents the community, has interpreters, has materials translated in Spanish, has marketing strategies to reach those populations, has community health workers, et cetera, patient navigators. It's a lot different. That culture of that service delivery system is a lot different than a mainstream hospital. Right? So there's different kind of cultures, and obviously patients that go to that hospital, their experiences are going to be a lot different versus a federally qualified health center. So how do you look at, let's say, the strategies or the interventions that a federally qualified health center uses to address the needs of those diverse populations? And how can those practices maybe be adopted or adapted by those hospital settings to address the needs of those patients that have, you know, particular kind of chronic diseases?
So the single biggest problem in communication is the illusion that it's taken place.
Yeah.
Again, please identify yourself for the purpose of the video. I think that's Lori over there. I can't really see.
Yep. Hi, thank you. Is that on? Yeah. I appreciate following Rima and Bernie's comment. I'm Lori Francis from the Oregon Primary Care Association, so I work exclusively with federally qualified health centers. And have comments for all of you, but especially Dr. Androulis. So, and I brought my computer because I wrote notes that tied a few comments together. And this crowd knows I'm sort of mildly and chronically irritated incessantly about how we bridge the health literacy world with the patient-centric world. And I think we still have a long way to go. I appreciated the nesting dolls. So my comments are, in terms of provider communication, I think I saw that on your slide, Dr. Androulis, and cultural competence. I think it's implied that the provider would become a better listener and inquirer and interviewer, although I don't think we do a great job almost ever in doing that. I saw in some of the other slides a reference to the strong ties to socioeconomic underpinnings, the lens of the patient, shared decision-making. I heard Bernie reference at the beginning cultural beliefs about not questioning and the inherent power differentials that are always in healthcare. And before I ask my question, I want to add I'm from Oregon, so we do have payment reform. We have essentially moving toward value-based pay, and in part of a pilot where the FQHCs are under a capitated primary care model, meaning they could do anything. They could just have interpreters and community health workers and an occasional doctor thrown in. And yet, we leave our mental models poorly. So I would say from medical school training and a long history in this country, we still are using that somewhat effective acute care model, translating it to a chronic care model, and I think we all agree that it's relatively impotent to treat the social determinants that drive health and well-being. And health literacy, as Rima said so eloquently, we often try and help patients understand our world better using simple language, not stop to understand their world and their priorities. So my question and thought, or really question is, how do we move from, do we have to call out provider team, listening, communication, inquiry, just as we've called out equity? A lot of our work in this country actually will improve equity if we do it well. But we call it out because it hasn't really moved in the way we like. And I'm wondering how you see us being better able to go from lecturing gently and clearly with monosyllabic words to listening better.
Yes. Next question. No, I think it gets in part back to what Ruth asked about, I think, being more conscious about it and bringing. I mean, I don't mean in a effective way. Grounding it, bringing it up in visibility, recognizing that it becomes part of the narrative around patient care. That this bringing together these elements is not something that you assume, but you have to document and look at through, as Lupe said, through data, that you begin to discuss in crafting innovations and in moving ahead these elements on a concerted, active way. And then also, I think that the marketplace may have some lessons. I was sitting here, I was thinking of what we were talking about here. I'm thinking, as I said, nobody's looked at what these folks are doing on a day-to-day basis. People realize it's a make or break issue for those marketplaces. You know, so my feeling is, instead of staying within the world that you're working in solely, that you might look to other areas, other places where there is action taking place, and say, how are you doing this? How is it working? What effect have you seen it have? What training have you done to make sure that all three are integrated into the work that's being done by these organizations? How are you measuring how well it's working? What kind of complaints are you saying? Look, there are reference points in the law to, are you getting plain language, you know, with regard to your insurance? What about claims appeal process? What about complaints? So I think in some ways the marketplace may actually be a little bit ahead because it's been forced to do it, while the healthcare field has been churning and gurgling and thinking about it, and not thinking about it in a lot of ways too. But so I think it's a combination of factors. I think, again, coming back to Ruth's point about documenting where value is playing out in new initiatives, making it part of the dialogue in asking about the innovations that are occurring and saying, how are you going about this? Where is this playing out? And then looking to where it actually may be working. You know, I suspect it is.
Can I just jump in? I know the time's short, but I mean, a lot of what I think is what I've been grappling with, and you made the comment about patient-centeredness and Rima's point, you know, that there's a lot that we don't know about patients that affect their engagement in healthcare, and even, you know, I think we've even shifted on things that it's not just about trying to make sure they do what we want them to do, but that at least a conversation is had, that a resolution is occurring, that some sort of, again, shared decision-making. But to me, it's this, you know, what we're grappling with is this balance of, and kind of the fourth bullet I didn't get to say, you know, is that, you know, people seem to, what we hear is caring about is what we've already talked about, is efficiency. So how do you deal with this drive for being efficient as a healthcare system, to recognizing that that doesn't always do well when we realize we don't know a lot about the patients you serve, and all these things that don't get brought out into the open, like health literacy skills, like beliefs about, I mean, all of these factors that ultimately impact them, because the patients, for the most part, are really in the quality control seat. They're the ones that are actually making decisions 99% of the time when they're not engaging with the healthcare system. And until that gets kind of
tapped and explored and beyond a 15, 20-minute encounter, and that there actually is a relationship to be had, and that can be viewed as something that is worthwhile from a healthcare system perspective. I think that's why the comment I stopped at the beginning is I feel like there's stagnation, that there's a lot of things that we would like to have happen, and many of us researching this in the field know should be happening, but it's the implementation that we keep struggling with.
So just to keep us on time, I'm going to ask just the three people who are at the microphone, and then we'll take a break thereafter. Michael?
Thank you, Michael Pashorlo. A few things. I really am happy that several of these topics have been coming up. I like the LLC. One thing I'm not happy about is I would say affectively you guys are at an anger level of about like a 1.5 or a 2. And like I'm really pissed off about some of these topics, and you're not expressing enough anger in my view. So some things actually require evidence, and I think, Dennis, I think it's excellent for you to point out we should be learning from things that work. But other things require direct advocacy. What are we thinking when we see patients that we cannot talk to them in the same language at all? Like we don't have this. If you're like a speech and language pathologist and you're talking to someone in another language, what are you doing in that appointment? If you're a psychiatrist and you're meeting with a person in another language, what do you think you're doing in that appointment? There's so many things wrong, and I would say there's a deep, the primary initial cultural, cross-cultural phenomenon is between the providers and the patients. That's the primary, even though there's variations between FQHCs and other kinds of settings, the primary one is this deep iatrocultural foible that we think that it's about us, and it's really not about us. Like it's about us for like 3 minutes when they're in our office, and then otherwise it's about, I would say in the end, there are some parts of this that require clear, very, very strong advocacy to start with, and then we also have to learn how to do it. We have to learn how to do it. So it still turns out that most of the time that clinicians are talking with patients with whom they share no language, that they don't bring in professional interpreters. That's still the case. So like, it's very important to hear scenarios where Wilma has to step out of her role of interpreter because the jargon that's coming out of the provider's mouth is unfathomable for her to be able to but that's the minority of the time that she even gets a chance to be there. Okay, that even gets a chance to be there. So part of this is kind of saying, that I'm very happy that you brought up the OCR, as an example. It's just a kind of a starting point. That as a reference point. This is actually a matter of your civil rights in this country. So it's good to talk about evidence. I'm all for it. Like I'm an evidence guy. I love it. But we got to start from a place of very core central advocacy. So my question to you is, where's the anger, and what about this would you like to say, yes, I'm angry about this?
I'll go first.
Well, I guess we need a Bernie Sanders to help us. But,
You don't have to get angry, by the way.
No. We're missing that progressive element that's been lost, and hopefully it's coming back. And in terms of the civil rights kind of movement for healthcare, if we look at 50% of the U.S. is controlled by the 1%ers, the wealth, and so economic inequities is becoming now a big issue, and hopefully that could be a driver that can, incentivize us folks who are here and maybe you folks in the audience to really start pushing, like the Office of Civil Rights, to really start enforcing some of their guidance, some of the laws that impact the civil rights of individuals who are trying to get access to health care, that can address health literacy, that can address cultural competency kind of issues. So I think there is a movement, and hopefully the next generation will pick up the baton and make it happen. So I'm hopeful that things will get better to address these kind of issues that we're talking about today.
You're hopeful, but not angry enough.
Michael, there's a difference. There's a difference between advocacy and anger. You can be a good advocate and not be angry. So I think what they're trying to say is, yes, pick up on the advocacy piece, and for sure, but not necessarily the anger piece. I mean, there may be a little fine line there.
I'm going to step in on Wilma for a second here, but what's important to me is passion about this.
Yes.
To have a passion about it. The anger is not useful. The passion is. And especially the passion, my goal is to find the tools that you and others can use, and me can use, to advocate passionately and in a way that convinces people. Anger oftentimes does not work. Passion does, though. Passion people get it, especially when you ground it with things that are potentially useful. So that, I think, you'll see in all of us, and is in all of us.
All right, so this is like a whole don't get me started topic. And the Chicago Southside accent might come out because that's my tell. All right, so, yeah, spoken like a true clinician, because as I go in there, not only am I wearing my interpreter hat, but I'm also wearing my MSW hat when I'm working with some providers. And as I said regarding self-assessment and language, there are many fragile egos out there when it comes to that, right? So I will get, I talk to our medical students and I remind them, don't forget to think about, whether or not you ask your patient, in what language do they get sick? In what language do they access their emotions? And you mentioned two areas which are, for interpreters, for myself, nutrition is one of the harder things to interpret because the foods are all over the place in Latin America, although we're generalized under one umbrella as Spanish speakers, right? For speech path, the construction of where the lip and tongue placement is, somebody asked me to interpret for coming from pediatric subspecialty, whether or not they're going to place an NG or this child is having cleft lip and palate surgery. Can they pronounce, this or the word or the other? Well, is that even going to make sense to you? So is a common factor more asking them to pronounce SpongeBob, where you have to pronounce an S and a B, right? And these things are done not in the moment, but in preparation of, right? The other one is any issues involving mental health, because you're assuming that the conversation is going to be linear and not a word salad. But as I'm calling myself an interpreter, right? I'm the conduit. So I have to be prepared to start interpreting a word salad as opposed to a linear conversation. Or when I worked with an adolescent who was having visual hallucinations and auditory hallucinations, the provider said, this is Wilma, you can touch her, she is real. And I had to interpret that. So these are all the different nuances of when we're dealing with language access. So the passion, I completely agree. Sometimes the challenge, and I'll be very honest, because I don't want to generalize that, providers are working in the absence of this information. Not always, right? Sometimes there isn't the awareness of the systems in place, and that creates a challenge. So being aware of those internal policies and organizational pieces, as I used to tell our medical residents, use me to help you work smarter, not harder. And I also have to be careful on how to navigate some of these situations, issues of saving face and not losing face and not doing anything to undermine that patient's confidence in her provider or his provider. I have to be very careful because you know what? If I do something that can taint any of this, that provider might not call me back, all right? And then they'll use their own skills because it's been generalized that interpreters are difficult. So these are all the fine lines that we have to walk. Trust me, sometimes the anger is there that's channeled into, all right, the positive is that they used us. The positive is that. So we try to find our positives where they can be. However, also talking to individuals, our patients and providers regarding Title VI, where I can very passive-aggressively say, well, you know what, this can be interpreted as a civil rights violation, which can be reported anonymously and not by the patient, right?
So I'm going to...
Subtle. So anyway, again, don't get me started.
So we have two persons at the microphone. I'm just going to ask that you just ask the question so that we can get through the rest of this period. So go ahead.
Marshall Chin from University of Chicago. It's a question for Michael. A couple times you mentioned that you thought that the three fields that are the focus of this workshop have stagnated to some extent. I wonder if you can tell us a little bit more about what you think the stagnation is and what's the single most important new direction you think these fields should go in.
Wow. So, I think that the stagnation from my perspective, and again, I can speak mostly to the health literacy end of it, is that, we continue to have we continue to do, I think, poorly at disseminating, I think, best practices. And I think also, to step back, I think we're still in the learning phase in terms of having a strong evidence base as to what those best practices are. And we do a lot of one-offs, and I think that there's really, for us, we've had few wins, a lot of gray wins, a lot of basically inconclusive evidence in terms of a lot of investment that NIH and others have done. And I think that we also have, just to be blunt, I think there's also a lot of factions that have kind of developed. I think we need to have a united voice, and I think the IOM Roundtable is very good on it as to what we're actually talking about, what a good evaluation of it. What is a health literacy intervention? What does it mean to be a health literacy intervention? What does an evaluation comprise of? And I remember still coming back to some IOM meetings ways back when Ann Beal made some great comments that I think really informed what maybe a good evaluation for an intervention like this would look like. And I think we keep moving the bar a bit. So I think what our expectations should be and what our field really is has to be somewhat very much, I'll almost argue, operationally defined. What is it going to look like? If you tell a healthcare system, from a health literacy perspective, these are the things you should be doing, I think we need to be far more articulate. And we need to really kind of have a more cohesive sense of what our evidence base is, what we can impart, and where the next hole should be. And not so in such a kind of fragmented piece.
Thank you.
Next question.
Sure. Bernie, this will hold. If you want to end now, my question will hold.
No, go right ahead.
All right. It's Andrew Pleasant, Canyon Ranch Institute. And this actually does tie on to what Michael was just talking about in the business case earlier. Evidence is clear over decades, right? To get policy change, numbers get you in the door, but stories win hearts and minds. So, yet, the ACA and PCORI, which you all allotted, is providing all these fabulous opportunities to advance health literacy, language access, cultural competency, explicitly goes out of its way to defer people, some would say actually prevent people from using metrics like the quality adjusted life year to actually achieve the ends that you're trying to use. Now, I've used the quality adjusted life year, and it has demonstrated very clearly that health literacy, integrative health prevention, intervention can create health at lower costs than most other medical interventions. But that's exactly what the ACA and PCORI are prevented from doing now. So what I'd like to hear from you is how strategically should these fields align to sort of change that discussion? And whether you want to call it a business case or ROI, it's still we need specific metrics, and that's exactly what we're told not to use right now.
Well, I think there are some efforts to try to backdoor around some of these restrictions. I think some of the work that ARC, the National Prevention Strategy, others have tried to do, have tried to address a roadblock. I mean, I think it's something perhaps, this is a hard area for foundations to step up to because they don't want to spend their dollars. I have an interesting challenge personally on this, professionally right now, because the Robert Wood Johnson Foundation is supporting the creation of a National Health Equity Index. And I'm in partnership with Brian Smedley and Steve Wolf at Virginia Commonwealth to do this. When I raise literacy, language, and culture, it is a sidebar at best. And it's basically, yeah, that's important. And it took a bit. I mean, God bless my colleagues. I mean, they all kind of recognize it, but they're focused on other things. And the importance from our perspective, because of the work that I've done with my colleagues, directly, we know of the value. So it becomes a point of advocacy for us in the data field to step up and make a case and bring it forward to those who are predisposed, I think, to somehow engage in it, but are seeing their focus is elsewhere. You know, they're not doing that. So my sense is this world, we will do what we can. I think certainly my colleagues are up for this involvement, this engagement. So it is our responsibility to find ways in which we can embed it in this work. And I think to a great extent, with regard to other data efforts, it becomes absent the support from the traditional places you look to support, like Congress, that you have to find ways, both within federal government, which I think they do to a modest extent, and through other sources to bring that to a visibility and a place within other measures of equity that it belongs where it belongs. So, you know, I don't know if that answers your question. It's a difficult challenge to try to find the way in which the existing data sets or data sets that are yet to be can say, look, this is a natural for inclusion, and we need to find ways to take advantage of and also promote it. All I can say is, from my position, you know, I'm in a fortunate position in that we have a project that could, excuse me, could use this to the extent that we can find sources that can document.
Short response.
You know, if there's a will, there's a way, right? I think that there are certain congressional folks on the Hill that could be very supportive in trying to push this agenda. I think if you look at President Obama, when he ran into roadblocks with the Congress, what did he do? He issued executive orders, right? So I think there's ways that can be, we can address these kind of issues strategically in a way that doesn't harm those entities like Pcori, et cetera. So.
Thinking about that, and you're mentioning executive order, and that was one of the things that happened in New York State. We couldn't get a language assistance bill for New York State, but we were able to reach executive order number 26, which mandates the provision of language access services for the top 6 languages as identified by U.S. Census 2010. So that was something, and also too, working with the New York State Pharmacy Act, which requires chain pharmacies to provide these services. So there are strategic ways to do this. But again, you know, we have to approach things in a way that's going to create partnerships as opposed to creating steps backwards to the work that we've already accomplished.
So thank you very much for those very stimulating questions from the audience, by the way. And thank you for the panelists for those very stimulating presentations and answers. We'll take a 15-minute break and return here at 10:45 for the next session. Thank you.